Welcome back, Straight Talkers. Today I'm going to talk about enuresis and how psychiatrists go about making this diagnosis clinically. Enuresis occurs in 5 to 10% of 5-year-olds, 3 to 5% of 10-year-olds, and around 1% of those 15 and older. Daytime enuresis is more common in females, whereas nighttime enuresis is more common in males. There are high rates of inheritance with this disorder, and kids who have moms who struggled with this are 3.6 times more likely to have this, whereas kids who have dads who struggled with this are 10.1 times at higher risk. There are two types of enuresis that have been described, primary type and secondary type. So primary type is when someone has never established urinary continence, whereas secondary type is when incontinence develops after a period of established urinary continence. Primary enuresis usually begins at age 5, and the most common time of onset for secondary enuresis is between ages 5 and 8 years. So how is enuresis diagnosed clinically? There are 4 criteria that we psychiatrists take into consideration, and these are listed from A to D in the DSM-5. Criterion A states that there's repeated voiding of urine into better clothes, whether involuntary or intentional. And kids who struggle with daytime enuresis often defer voiding until incontinence occurs. And this is sometimes secondary to reluctance to use the toilet as a result of anxiety, or maybe even because they're preoccupied with school or a play activity. And daytime enuretic events typically occur in the early afternoon on school days, and many times it can be associated with symptoms of disruptive behavior. Criterion B notes that the behavior is clinically significant, as manifested either by a frequency of at least twice a week for at least 3 consecutive months, or the presence of clinically significant distress or impairment in social, academic, occupational, or other important areas of functioning. Kids with this often avoid sleepovers or camps. In addition, it can affect self-esteem and can lead to kids being bullied by peers. Parents also can struggle with this and will become frustrated, which can lead to anger, punishment, and rejection. Criterion C states that the chronological age is at least 5 years, or if there are developmental delays present, the child needs a mental age of at least 5 years. Criterion D notes that the behavior is not attributable to the physiological effects of a substance, such as a diuretic or an antipsychotic medication, or to another medical condition, such as diabetes, spina bifida, or seizure disorder. If someone has met criteria for enuresis, I will then take into consideration when episodes occur, and there are 3 different specifiers that can be added to the diagnosis. But first, make sure you hit that subscribe button so that you can be the first to know when new content comes out. Nocturnal only is when passage of urine occurs only during nighttime sleep. And this is the most common type, and episodes typically occur during the first 1/3 of the night. Diurnal only is when passage of urine occurs only during waking hours, and this is sometimes referred to as incontinence. And individuals with this subtype can be separated into 2 different groups, right? Those with urge incontinence and those with voiding postponement. Urge incontinence is when there's sudden urge symptoms and detrusor muscle instability. And the detrusor muscle is a muscle in the bladder that contracts during urination to release urine. Voiding postponement is when signs and urges to urinate are deferred until incontinence resolves. The last subtype, which is nocturnal and diurnal, is when there's a combination of the 2. When looking at the course of enuresis, what we typically see is that after the age of 5 years, the rate of spontaneous remission is around 5 to 10% per year. And most children will become continent by adolescence, but approximately 1% of cases will still have the disorder persist into adulthood. Now head on over to the next video to find out more ways to help your child live their best life.